Good morning, everybody. Those were the Eagles, as you may all know, even though they're kind of an old classic rock and roll band. I consider the Eagles not only the exact definition of what I call classic rock, but they're also like one of my favorite groups. This is Dr. Minarsik, and today is Thursday. It's August 8th. It's 9 o'clock in the morning in the Chicago time zone. And this is our third webinar of the year, of the 2019-2020 academic year. As you know, we started off with the Eagles over here, and we're going to play all Eagles songs today. And our graphic theme, both on our screen as well as on the Facebook announcement, is jungle. In fact, it's going to be all Puerto Rican jungle today. The topic for today, I guess we could call it cellular pathology, or I guess we could call it all of the things that could go wrong with you at the cellular level. Many of the chapters call it cell adaptation, cell injury, and cell death. We're going to do our little test right now, our AVM test, to make sure everything is going good. Although all my dials here, which you can't see, indicate to me that they are. A stands for audio. Can you hear me? I'm going to see if I could whip open the answer box. And I'm hoping somebody will type in yes. Somebody put in an S. I guess that's close to yes. Can you hear me? If you can, just type yes into the question box. I think everything is okay over here. Hold on. Maybe I'm not doing this good enough. Yeah, I'm expanding it. Now I got a bunch of yeses. Second question is, how many fingers do I have up right now? Just so not only the audio of the video, but the free video feed comes through as well. Good, we got that one right. And finally, I am very, very sensitive about the quality of the music, because the quality of the music is directly proportional to the quality of your hearing and the quality of your education. So on a scale of 1 to 10, what was the quality of the music? I got an 8. I'm very happy. I was thinking of experimenting with a new method, but as long as this is going good, I don't want to screw with it, because audio is like boggling my mind. This is the topic for today. If you notice, we have 66 PowerPoints, and they also have 66 scribblings on here. I spend a couple of hours the day before a webinar, and especially the night before, to go over all of the material, added anything new, maybe rearrange things if I could explain things easier. And then I scribble it down on here. I guess you could call it all my PowerPoint zipped into one. So let's get going. I'm going to put this little question box back here. And I am going to also close this ugly guy over here. And we're going to pop up the PowerPoints. And we'll start talking about disease at the individual cellular level, also called cellular adaptations, cellular injury, and cellular death. So there we are at PowerPoint number 66. So we're all over. We're all through. So let's go back up to number 1. And number 1 is basically the title of the presentation. It's also the title of one of the chapters of Robbins. And, you know, if you want to understand disease in people, you have to understand disease in cells. When a person gets injured, cells get injured. If the cells can respond to the injury, there is no death. If the cells and the person cannot respond to the injury, there is cell death. Okay. So an injured cell can either adapt or it could die. I guess you could say that. So the objectives, some of which we opened up in the previous webinar, is that no matter what kind of disease we're talking about from a cellular or morphologic, or we'll say microscopic point of view, cells can either degenerate, they could become inflamed, or they could proliferate in a neoplastic fashion. We're going to be talking about the classical words that you'll hear in the medical literature all the time, like hyperplasia, hypertrophy, atrophy, metaplasia. And I'll pertain to changes that happen on a cellular level. Then we're going to go a little bit into the chemistry and deeper in, talk about some of the factors of cell injury. What's the effect of oxygen or lack of oxygen? What are some of the effects of physical injury like radiation or trauma? What about the chemical injury? So probably you'll learn about 1,000 times more about this when you get to pharm if you're not in pharmacology already. But I want to touch on it as well. Infection, immunologic diseases, genetic diseases, nutritional diseases. We're going to talk about these changes from a cellular level. And of course, we'll be talking about changes also at the subcellular level. What happens to the mitochondria? What happens to ATP? What's the effect of free radicals as both a cause or an effect of cell injury? What about the cell membranes? What happens to them in reversible and irreversible changes? One of the key things that we really are going to be spending some time on today is the concept of both apoptosis and necrosis. And if you want to think of these two things as two separate things, you can, but they're really kind of like on a spectrum. A cell dies normally, like people die normally, and they're replaced by a concept called apoptosis. Believe it or not, when I took pathology course, about 1 million years ago, Robbins' second edition, the word wasn't even in existence, apoptosis, and now it's one of the key features. Of course, necrosis is cell death, not only from a physiologic point of view or a functional point of view, but also a microscopic, pathologic, morphologic point of view. We'll talk about some of the things that also happened in cell injury, like what do the lysosomes do, what happens to the smooth endoplasmic reticulum, all these subcellular things that I'm sure you have heard of and hopefully heard of in great detail if you took a cell biology course during your anatomy years or year. Also, we're going to talk about what happens when things accumulate inside of cells. Well, if you take the textbook of biochemistry, you know we have fats, we have carbohydrates, and we got proteins. And all of these substances can build up in cells through pathologic processes, and even pigments, not only pigments that are intrinsic or endopigments, but also exopigments, okay? And then we're going to spend a word at the end, kind of talking philosophically. That was PowerPoint number 66, about why do cells die? Why do people die? You know, I think you could probably draw a very, very, very good parallel between the two in almost every deep or philosophical endeavor. So we know pathology is what the course you're taking. We know that the pathos is a Greek word for suffering or pain, probably more suffering. And logos is the study of. So we're going to be talking about all year the study of suffering. We'll probably also be suffering all year as well. Most of the ways that the course is divided, whether it is called general and systemic, or even if there's a systemic or block approach, or systems approach to pathology. There's always a big discussion on general, and of course that's about the first 10 topics, or let's say, I think it winds up being something like 14 webinars, which the students from San Juan Bautista are going over the movies from last year right now. General pathology are things in general, like cell injury. That's a great general pathology topic, or neoplastic disease, or immune diseases, or genetic diseases. And then in the systems, of course, you go into the classical 10 or 8 type systems of the body, depending on how you group them. And that'll be the majority of what we talk about this year. Every disease has to have 4 things. It has to have a cause, call that an etiology. It has to have a pathogenesis. And if you remember, we showed you that picture of keep on pathogenesis-ing at the beginning of the webinar. It's a very, very interesting concept that I pretty much think about several hours a day, even if I'm not preparing for a webinar. The morphology is abnormal anatomy. Could this be gross anatomy, microscopic anatomy, radiologic anatomy? Every disease has to have an abnormal anatomy. And these are the principles of Dr. Virchow, the father of pathology. Remember, it wasn't that long ago, maybe not more than about 100 years, that most people thought diseases were caused by evil spirits. Now we know that they have causes or risk factors. And of course, the clinical expression of a disease. Now, many of the changes of a disease could take place without actual overt symptoms. But one way or another, these things could be measured by lab tests or biopsies without an actual physical symptom of the patient. So if there's a disease that doesn't have symptoms, or at least as felt or expressed by the patient, we call that a subclinical disease. Etiology is a cause. In many cases, a specific pinpoint cause is not always present. It's a combination of factors. Maybe we could boil it down to a mutation, or maybe we could boil it down to a single bug like Mycobacterium tuberculosum. But there's also other factors. And these mathematical factors working together generally can be, in most cases, replacing the concept of a cause. So a single bug might cause tuberculosis, but there might be many, many other factors in the patient that allows it, okay? So I think nowadays more things are talked about as being risk factors than actual pinpoint slam dunk causes. Pathogenesis. You know, this word has really bugged me for many, many years. I originally wrote it down a long time ago in my own words. It's the sequence of events, not only morphologic events, but physical events, things that happen, not necessarily things that could be seen. The sequence of events from the initial stimulus that causes the disease to the ultimate expression of the disease. And that's probably what we would call the ultimate clinical expression. You know, there's a lot of ways of looking at pathogenesis, so I thought, hell, I'm just going to go to the dictionary, a regular old medical dictionary, and define it even better. Pathogenesis of a disease is the manner of development of a disease. And remember, a lot of things could be going on between the cause of a disease and when you finally express the disease in terms of symptoms. And that is probably what we would call a pathogenesis. And sometimes I even use the word insidious. And maybe I'll use the word insidious again, because often it's before the disease as experienced by the patient actually occurs. Morphology of a disease might be, you know, a bunch of tumor cells. It might be a lump pressing on the aorta. It might be a radiologic finding. Or if we want to go further, it could even be at the molecular level. You know, the more I think about it and the way more disease and medicine and pathology is going, I think that morphologic changes of a chromosome or genes on a chromosome can, in a way, be thought of as morphology. Now, it's not like you could see it with your eyes or under a microscope or with x-rays, but now we could see them in a way with a variety of tests. And of course, the best lab in the Chicago area that does this is called GoPath Lab. They're also best because they support my webinars as well, thankfully, very thankfully. The clinical expression of a disease, even though it's called clinical expression, it may not be present in disease. So you really can't call it pathos. If you're not suffering, can you really say you have a disease? Well, you know, most of hepatitis is subclinical or without symptoms, at least physical symptoms. You may get enzymes that are sky high and other changes in the lab. Same thing with a pulmonary embolism. Most of pulmonary emboli people don't even feel. You know, if you have 100 soldiers sitting on a plane coming in from, you know, the Mideast, you know, back to Washington, D.C., they may all feel fine when they get off the plane. If you do a study, you could probably find that if they haven't moved around a lot, they probably have flaked off a few emboli into their lungs, which they don't even know about, during the long trip. And that's why if you've ever gone overseas, you might remember the time when the stewardess says, "Okay, everybody stand up. Let's do some leg stretches." So that's why they're doing that. Okay. Uh, I think the best way for you to understand a disease is to visualize it. Okay. Now, there's a lot of ways you could visualize it. You might think of an x-ray showing a mass. But, I'm a pathologist, so most of the diseases that we talk about, we're going to show you an image, a gross or a microscopic image. Okay? And almost all diseases can be diagnosed or seen at the regular old light microscopic level. In fact, I got news for you. You probably won't believe it, but if you do an autopsy and you're looking at tissues and organs with your bare eyes, you can probably predict microscopic changes. In other words, you might see a liver and it looks a little yellow and you say, "Oh, I don't know what that is." But if you are a good pathologist or an old-time pathologist, and you've done a million of them, you can pretty much quantitate the amount of fat that you're going to see on a microscopic slide. Remember this guy here? His name is Rudy Virchow. He's the father of pathologists. All pathologists love Rudy. If you go to a party and somebody says something bad about Rudy, we're probably going to punch you in the face, okay? He is the father of pathology. He has a profound effect on medicine and the way we look at diseases. And all he said was, all diseases are basically the result of cellular changes. And that's what we're going to be talking about, cellular changes. And here is my other hero, my personal hero. In a way, I think he looks a lot like Rudy Virchow. His name is Vinay Kumar. And if you don't know who Vinay Kumar is, it means you haven't bought your damn Robbins textbook yet, because he's been writing it for years. And basically, this course is based largely on the outline of his book. Now listen to this part carefully. And the outline of his book is based on the list of objectives sent to us by the USMLE. So not only did he say that 60% of all questions come from pathology, but 60% of all step 1 questions can probably be looked up in his book. Another way to define disease, if you want to think functionally rather than anatomically, is the concept of altered homeostasis. You all know what homeostasis is. It is the normal balance of processes, which sometimes can be measured in the lab by lab tests. And if those processes get out of balance, or lack of homeostasis, even if the anatomic changes are not there or you don't care about, that'd be another way of defining disease as well. Okay, so now that we talked about all kinds of normal things, let's talk about the obvious. Cell death. Cells die. Cells have to die. Lymphocytes might live for only a couple of weeks or a couple of months. Epithelial cells from the GI tract or the bone marrow might live only a couple days. Red cell live 30 days, 90 days. Even cells that you think don't multiply too much, kidney, liver, they don't live forever. They're replaced. Okay, now it's sad that they die, but they're replaced. The normal replacement of cellular death is called apoptosis. Okay, I want to say something else about that. Oh yeah, do you remember all those cells that you had in your body when you were an embryo? They're not there anymore. Guess what? They all apoptoted, didn't they? Okay, or remember when you had that big boil in your arm, that big abscess, and it's not there anymore? Well, where do you think those cells went? They died too. Normal apoptosis. Now, another way to kill a cell is not to wait for it to die because it gets old, but is to injure it. Okay, so the necrosis is actually another way of looking at apoptosis. You want to think of these as two different processes you can. However, listen carefully. The changes that you see microscopically in both apoptosis as well as injury necrosis are virtually identical. So you might think of the apoptosis necrosis as a spectrum rather than two things. In fact, there is a legitimate term used called pathologic apoptosis, and for all practical purposes, pathologic apoptosis is pretty much the same as necrosis. Now, do you remember Snow White and the Seven Dwarfs? You know, Happy, Doc, Sneezy, Sleazy, all those guys. Well, there were 7 of them. And there's also 7 plasia brothers as well. Now, you know, plasia is the root word for growth. So you would think that hyperplasia would be increased growth, resulting in increased number of cells. You might think that hypoplasia is decreased growth or decreased number of cells. Or if you want to use the word aplasia, which means no growth, it means there would be no growth or practically absent cells. Sometimes I would even use the word normoplasia. Not many people use it. I don't know, if you Googled it, you probably wouldn't find too many examples. But if you are examining tissues, like in the bone marrow, and you see that there is a normal pattern of growth and a normal number of cells, sometimes I would use the word normoplasia. I'm probably not the only person in the world that did it. Metaplasia is a key concept, and we'll be talking about that many times this year. Metaplasia means normal growth and normal appearance of cells, but they are in places where they normally wouldn't be. And the best example of that is a squamocolumnar junction, like you have in your gastroesophageal or anal rectal or cervix, in which you have squamous on one side and columnar on the other side. Well, if the columnar part is now subjected to the same forces or trauma that is normally only in the squamous part, those cells are going to regenerate in such a way that they become squamous. And those are probably the classic examples. So I would say probably 95% of the time, maybe 85%, when you hear the word metaplasia, it's probably referring to the squamocolumnar area, but it could be anywhere. Dysplasia is abnormal growth. Now, in most cases, most times, when we use the word dysplasia in medicine and pathology, we are referring to abnormal growth or cells that look abnormal. So I know what you're thinking. You're thinking, could dysplasia usually mean pre-malignant? And the answer is, you're goddamn right it does. But there are other times the word dysplasia is used and they don't really mean pre-malignant. But for them, we'll talk about those as well. Okay, especially in pediatric diseases. Now, the word anaplasia is even worse than the word dysplasia, because whereas dysplasia might mean atypical cells, anaplasia means downright cancerous cells. In fact, sometimes to emphasize it, you might even Google this or put this into, you might even see the word frank preceding the word anaplasia, because they're saying it's not malignant, it's damn malignant, or it's frank anaplasia. Frank anaplasia is not a famous pathologist. So here's hyperplasia. Take a look at the normal adrenal glands in the middle. The cortex is yellow. Why? Because it has a lot of cholesterol fat, so it could make the steroid hormones. If the yellow ribbon, which is only about 1 millimeter thick, is practically zilch, that's decreased growth or hypoplasia. But if the yellow ribbon is thick, maybe rather than 1 millimeter, maybe as you could see here, maybe 3, 4, 5 millimeters, then that's hyperplasia. So normal adrenals, hyperplastic adrenal cortex, hypoplastic adrenal cortex. So there you go, hypoplasia. What about the word Trophy. Trophy doesn't mean growth directly, but it means more like size. You know, something that's a cell that is hypertrophic doesn't mean it's multiplied and increased in numbers. A hypertrophic cell is something that's increased in size. So when they talk about a heart being enlarged, is the best example. It doesn't mean that there's twice as many cells in the heart or myocardial fibers. It means that the myocardial fibers are all larger. That's hypertrophy. Of course, the opposite of that would be individual cells that are smaller than usual, would be hypotrophy. But to tell you the truth, I can't even remember using the word hypotrophy commonly. Okay, very often you'll hear the word atrophy. Now, the problem with the word atrophy, which means smaller than average size of cells, is that it's very often or more likely to be replace the word aplasia or hypoplasia. So remember, not only are these words used incorrectly, but sometimes they're used interchangeably. Now, what is dystrophy? Dystrophy does not mean premalignant at all. It usually just means a nonspecific word like pathologic, like muscular dystrophy, pathologic changes in muscle. It doesn't mean increased cells, decreased cells, bigger cells, littler cells, malignant cells, atypical cells. So dystrophy is something that does not really correspond to what we've been talking about. Classical example of hypertrophy. You might remember that the normal weight of a heart for an adult is about 300 grams, which this one is. If it's hypertrophied, it might be 600 grams. Now, does that mean there's twice as many cells? No. What it means is that each cell is twice as big. Okay, so these fibers here have increased in size, not numbers. And this is the same magnification power. And you can see these not only nuclei are bigger when they're hypertrophic, but so are the whole fibers. Is there a word hypotrophy? I guess technically it would be possible by our strict definition, but it's a term that is very, very rarely used. I can't think of a single disease offhand that's called hypotrophic, this or that. However, the word atrophy very often really is used instead of hypoplasia or aplasia. So technically the word atrophy would be not only in decreased size of the cells, but no cells. So if you have no cells, you're more likely really meaning hypo or aplasia rather than atrophy. And atrophic cells technically would be increase or shrinkage of the cell due to loss of cell substance. And wouldn't that technically be the same as hypotrophy? Yes, but remember, people don't say hypotrophy anymore. They say atrophy. Why would cells be decreased in size? Well, maybe because they're decreased workload. If you remember, when you were a young kid, you had big muscles. I think they call them guns, or maybe you had a six-pack abs. But if you're not exercising, or you get old and you don't exercise, those cells decrease in size. Maybe if you have muscle cells that have lost their innervation, like in many of the neuromuscular diseases, they would be decreased in size, like in the muscular dystrophies, do also be called atrophy. Maybe they're small simply because they're not getting enough food. They're not getting enough oxygen. They're not getting enough sugar, okay? So a decreased blood flow would be another general concept of atrophy, decreased nutrition, and aging. Okay, well, people that are older, they just don't move around as much, but they also have withdrawal of a lot of hormonal processes, and the classical example of that would be thyroid. You may have wondered why last year all of your thyroids weighed, 10 grams rather than, 20 or 30 like they should. And that's simply because people get older, their hormones basically get withdrawn, and therefore the nurturing to a gland or a tissue makes that tissue or gland or substance smaller as well. If you put your fist against somebody's pancreas, for a long time, the pressure, probably resulting in decreased blood flow, would also be definitely a concept in atrophy as well. Okay, let's go back to metaplasia because it's very, very important. It's a substitution of one normal type for another. The most obvious and usual example is squamous epithelium replacing columnar epithelium. Squamous metaplasia, right? And that could be at any squamo-columnar junction. It could be at the anal-rectal junction. It could be at the gastroesophageal junction. But technically, you can also have columnar epithelium replacing squamous epithelium. So let's say that the esophagus is squamous epithelium because it doesn't need to have columnar cells to neutralize acid, okay, because there's a sphincter there and nothing is regurgitating or reflexing. But let's say there is reflux, then some of those columnar cells in the esophagus will now become squamous, so they could produce glandular cells because the glandular cells secrete mucin, and mucin basically neutralizes acid. Could you have a fibrous tissue replacing bone or bone replacing fibrous tissue? Yeah, that's possible. That would be a metastatic process. And we've already explained to you why. The reason why one cell type replaces another cell type is that it becomes necessary if it has a new role to play. And remember, whether you look at the basement membrane of a columnar epithelium or the basement membrane or squamous epithelium, there are cells there, you might call them limited stem cells, that can differentiate in either direction, either squamous or either columnar. So it differentiates in the direction that it is needed to do its job. That's the classical example of cellular adaptation, which this chapter is named after. Now we're getting to a big discussion about cell death, cell injury. We already talked about apoptosis versus necrosis. But you might say, well, what does cell death mean? Well, what does a human death mean? Or you might say, what is death? You might say, what is life? Now, rather than talking about death and life being the opposite of the other, the key word that defines death, cell death or person death or any kind of death, are irreversible cellular changes. If a cell cannot function at all, okay, then irreversibly, forever, then you would probably call that cell death. So the question is, it's not what is life or what is death, but what is reversible or what is irreversible. Cellular cells that are injured may be injured reversibly, okay? And that means they might be able to adapt to go back to normal function. But if the processes that are injuring the cell are continue or get worse, that cell could then progress into the irreversible thing. So let's not talk about life and death. Let's talk about reversible and irreversible. Here are some of the reversible changes, and I think they should all be logical to you. What would happen if a cell doesn't get oxygen? Maybe because of a mitochondrial problem or a blood problem, or if the mitochondria aren't getting oxygen from blood and there's reduced ATP or absent ATP, that cell's going to die. So persistent ATP depletion would be an obvious cause and probably the most usual cause of reversible changes. If that depletion continues and does not adapt, then that cell dies. But ATP depletion in itself is a reversible change. What about cells that swell? Cells that swell mean they probably have some membrane problem. Maybe they are not able to activate their sodium potassium pump, and therefore they can't pump out the sodium enough, so water excuse me, accumulates within the cell. So cellular swelling is also reversible change. But remember, these are also changes that may precede cell death as well. And remember, we said we're going to talk about death as being irreversible. So how about if we make this very easy for you? If the mitochondria die, the cell dies, okay? If the mitochondria are irreversibly injured, the cell is irreversibly injured. Or we could say the same thing about membrane defects, okay? If you have cellular swelling because of a reversible problem, that doesn't mean death. But if that membrane defect is irreversible, then the cell is irreversible. So most cells swell before they die, but just because they swell, that doesn't mean that they're dead. Here's another really obvious one. There are mechanisms in the cell at the single cellular level for lysosomes, the digestive enzymes in lysosomes, to start chewing up the dead or injured part of the cell. So if you have a cell in which the lysosomes are already starting to chew up the dead parts of the cell, I mean the cell may be dead. Can I give you a really good example of that? And somebody said this is a gross example, but see that bug over there? I had a bug like that on my doorstep once, and I was looking at it, and it wasn't moving. And I thought, oh my God, is that thing still alive? So I bent over and I looked at it even more carefully, and look, it's not moving. I don't know if it's dead or alive, but look, the ants are already starting to eat it. So when the ants start eating the bug, the bug's dead. When the lysosomes start eating the cytoplasm, the cell's dead. Okay, this we have already alluded to. Reversible changes are called cell injury. Irreversible changes are called death. And some injuries can lead to death if they are prolonged and or severe enough. I think that's that's one of the greatest, clearest concepts to understand. Let's see, should I take a break now or not? No, I'm not going to take a break because I like these guys. They're called the usual suspects. You may not be old enough, or you may not have seen the movie with Kevin Spacey called The Usual Suspects. In other words, when there's been a crime that has happened in a neighborhood, the police get all the people that they know are bad guys, and they line them up, and they put them before the person or the victim of the crime, and they say, well, was it this guy that robbed you, or was it this guy? So there were always people that the cops dragged in that were people that were known criminals, and chronic criminals, we'll say, and they were there. They're called the usual suspects. So when we talk about the millions, thousands at least, of things that could possibly injure cells, if you want to lump them into three usual suspects, you could say this. They are the physical agents, like radiation, trauma, for example, or chemical agents. And not only could they be toxic chemicals, but they could be pharmacologic substances. So you're going to be learning the whole year about as much as you do in pathology about chemicals, drugs that can also cause side effects, which is going to be a cellular, hopefully reversible change. And then there are the infectious agents. This whole long list of bacteria, viruses, blah, 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 all of these having a direct effect on cells that might cause reversible changes. Now, it's obvious that almost no matter what the process is, hypoxia is almost always one of the underlying causes. So if you want to say hypoxia is the king of the usual suspects, you can. So we could say decreased oxygen causing a reversible change. If you go to the dictionary and look at agents or words that could be used as causing injury, you could talk about immunologic diseases, genetic diseases, mutations, nutritional injuries. But the big three suspects: physical, chemical, infectious. And by the way, what do these three things all have in common? Besides the fact that they just about cause almost every kind of disease we'll be talking about, what they all have in common is that they are all mutagens. They can all cause mutations in cells. So we cause a mutation in your genome, and that opens the door for just about all of the things. So if you want to say mutagenic agents, you can as a fourth usual suspects, but all these three things are mutagenic agents, whether you're talking about cancers, whether you're talking about teratogens or birth defects. Basically, these are all potential mutagens. So let's look at it in another way now. Decreased ATP could injure the cell, in other words, be reversible. But it could also be the result of the cell being damaged from another process. Same thing with the mitochondria. If you have a primary mitochondrial disease, and believe me, there's zillions of them, even though you may not have heard of any one in particular, that could damage the cell. But if the cell is damaged from another way, the mitochondria could be damaged as well. Same thing with calcium. When a cell is damaged, there is an accumulation of intracellular calcium. Now, that doesn't mean the cell calcifies or that you see calcium crystals, but the calcium could be the result of cell injury, or it could be the cause of cell injury. And what I just said is especially true with this concept of free radicals. Now, you know what free radicals are chemically. They are basically substances that are not really ions. They're unbalanced. They're free things floating around looking to connect with something chemically. These free radicals can injure cells terribly, do terrible things to cells, even DNA. But they can also accumulate when the cell is injured from other reasons. Same thing with the membrane. If a membrane is defective, if it's injured, that cell is injured. But an injured cell from another cause will often result in decreased cell membrane. So we talk about almost all the causes of irreversible or cell injury. They can also be thought of as being all of the effects as well. I like that slide. How about if we take a break now, because we're more than halfway done. Let's play a couple of songs, and I think we've been doing pretty good so far. Maybe I'll filter my coffee and take Woofy for a little walk. So we'll play some music and see you soon, like maybe in about